the voice is clear. Okay, so when they vote for you the case, you have to start a description. So if someone want to join me in the chat, it would be nice. So let me ask you, if you see this uptake in such case, is it intense or mild or moderate uptake? What do you think? And which anatomical bone is this intense uptake? Yes, in the calcaneus, exactly. So in such case, I think everyone will be happy that he will say some differential diagnosis, keeping with this lesion. So what do you think? What is your differential, most probably diagnosis in your mind? Do you think that it could be inflammatory, could be neoplastic, it could be, as someone, Dr. Saad, Dr. Suwailam, yes, stress fracture, one of the nice differential here. And in such case, you have to mention that you will correlate with study. Usually it's X-ray, but the X-ray in the stress fracture, usually you will not find something abnormality. So usually go to the MRI, which is more specific to catch the stress fracture, which is a frequent question in the exam. So let's go to another bone scan. Then the question for you, this patient have pain, and the history of this patient that she have breast cancer as well. So you are worried, everyone worried about malignancy, metastasis. Then where is the abnormality? Here then the bone scan, I would recommend you such a scheme. If you start in the bone scan, you better try to comment in the renal uptake and soft tissue uptake. Then when you comment in this, you have to comment after that about the axial skeleton and the appendicular skeleton, and try to find symmetrical versus the asymmetrical distribution of the tracer. So anyone can tell me where is the abnormality? This is the challenge here. What do you think? Where is the abnormality? Sometimes, which is in the bone scan, sometimes it's tricky that there is a lot of degenerative changes. So maybe in the ribs, maybe in the sternum. Yes, there can be degenerative changes. Dr. Saad, he think about something very interesting. Exactly, yes. So actually, this patient have abnormal uptake, tracer uptake in the lateral side of the femur. Usually, the stress fracture, it go in the medial side as a common site for the stress fracture. But here, if you focus, you will find that this lesion is in the lateral side, which is typical for one type of the stress fracture, which is bisphosphonate-induced stress fractures. So in this case, you will ask if this patient take bisphosphonate for osteoporosis or not. Excellent. So you have to correlate with the X-ray again, and you correlate here with the clinical history of this patient have drug-induced stress fracture. So let's go in the another case in the bone scan, and usually again this patient have breast cancer, and right now she presented with pelvic pain. So what do you think? Where is the abnormality? Yes, this is typical Honda sign. This is the typical Honda sign, and in the posterior view is more obvious. So in that case, you are worried about what? Honda sign denote that this patient have which type of lesion? What do you think? Yes, it is typical for sacral insufficiency fracture. Bravo. Excellent. So in this patient, the examiner will be happy if they hear that you are confident to say that this patient, he didn't have any malignancy in this image. He have just sacral insufficiency fracture. And again, you will be asked to say that I will correlate with X-ray or maybe CT or MRI, which is more specific in the MRI. So in that case, everyone will be happy with your answer. Let's go to another case, another type. Yes, sometimes they have some degenerative changes. As I told you, this is common finding in the bone scan. You can find some changes in the symphysis pubis, in the hip, in the shoulder. Okay, so let's go to another type of bone scan. Another question, and this patient have some chronic history of something. And the question for you, where is the finding? Some people, they think about yes. So how we describe, if you find that you go to the diagnosis, that's nice, but try to describe so you can take also good mark in your description. So, is it bilateral or unilateral? Is it symmetrical or asymmetrical? The distribution here is very important before you jump to the diagnosis. So you will be telling the examiner that the distribution is patchy, peripheral uptake, taking tibia, yes, rather symmetrical, exactly, perfect. And it is in the cortices, in the cortical. So in such case, as you mentioned, you are worried about hypertrophic pulmonary osteoarthropathy as a differential. There is also other differential like venous insufficiency. Maybe someone asked, what is this? Anyone know what could be this one? This is catheter, yes. So sometimes there's some artifact, maybe some bags, some catheters in the study. So take it easy. Sometimes you can find the injection site. Okay. So actually, the main finding here is the uptake along the cortices of the long bones, especially in such case, everyone will be happy if you say that you will correlate with X-ray. First, to correlate with the X-ray to check the next step, which usually the primary source of such appearance, which is pulmonary. Usually they say that pulmonary malignancy as bronchogenic cancer is the source, but it also can happen with any other lesion, pulmonary lesions. Everyone agree? Everyone happy? So this is the typical case of pulmonary hypertrophic pulmonary osteoarthropathy, which is again frequent exam case. So when you go to check for this patient who have chronic bony pains, what do you think? How describe this case? How you can describe? This is anterior, posterior, planar images of whole body scan. Demonstrate what? What do you see? What do you see in this case? Exactly. So actually, the best thing that you mentioned as approach for you to start with the kidneys and soft tissue. So when you find that there is absent renal uptake, and also you correlate with the soft tissue uptake, so is absent in this case, so you are worried about super scan. Then it's better to not stop, try to recognize, is it which type of super scan in this case? So what is the types of super scan? What do you think? They have metabolic and they have metastatic. Which one fit this case? Do you think that this go more with the metabolic or metastatic? And what is your evidence? Yes, your evidence is the mandible. Excellent. So when you find there is uptake in the mandible, so you think more that is metabolic super scan. But let me try to figure out something. Do you think that the metabolic activity, the tracer uptake, is more in the axial skeleton or the appendicular skeleton? Do you think that it's more in the axial or the appendicular? And which one you think? You think that the metastasis like the axial skeleton, which is rich with the red marrow, or the appendicular skeleton? Yes. So this case is typical for metabolic super scan because the metastasis like more the axial skeleton. And you can see here that the activity, the tracer uptake more in the appendicular skeleton, which going with metabolic super scan. But two things. You have to check the activity and you check for the skull and mandible. In such case, again, you will say, I will correlate with the images, the conventional images. And sometimes you can find the cause in the such metabolic super scan as this patient have transplant and he start to have even vegetoid features in the image in the bones. So this going well with metabolic super scan. Sometimes the bone scan can come to you in this image. And in such case, don't be panic. Don't have any panic in this case. Just take it easy. This patient have breast cancer. And the main finding here, just make reverse for the finding, the black and the white. He's not black, even white, but anyway, make just reverse in your mind. And then again, yes, again, this is Honda sign. And this is typical for sacral insufficiency fracture. I think it's better to say I will correlate with MRI to do again to confirm my diagnosis of sacral insufficiency fracture. So this young adult or boy, this boy come to you and he have a pain in the left hip. And what do you think? Where is the major abnormality? This is abnormal. Do you think that this is abnormal or normal? Yes, this is normal in such age. So all this is normal in this age group. So where is the abnormality? This is kidney. This is not abnormal even. So where the abnormality is here. Perfect. Excellent. Yes. So this is the abnormality. Is it in the left side or on the right side? What do you think? Left side, right side? Left side. Excellent. Because this patient is posterior planar image in the posterior view. So the differential side is osteoma. Perfect. So go on the CT X-ray. We'll find some sclerosis and some lucency inside. So you are thinking about osteoma. Let's go to check the CT. Yes, it is osteoma, which is typical. In the bone scan, they mentioned something that it have like something called the double density pattern in the bone scan. So this some cases that frequent cases that came. So let's see this patient who have some abnormality. What do you think? What is the name of this scan? Yes, do not sign. Okay. So this scan is called. Does anyone the name of this? Yes. System-EB. Okay. So this for parathyroid. So what could be there? Yes. could be parathyroid uptake. So you can note that the thyroid gland here, it should wash out, but the parathyroid adenoma in this case have accumulation of the tracer. In such case, is nice to mention that you will correlate with ultrasound. This is the good approach that you will mention. Then you also confirm your diagnosis and your concern about parathyroid adenoma. So if I show you this case, who have patient who have again chronic history, and he have a chronic bony pain. So what is your impression about this case? What do you think? This degenerative or metastatic? This is degenerative. So where is the metastasis? We mentioned that metastasis like the axial skeleton. So all this could be metastasis. Excellent. All this could be metastasis. So this is typical pattern of metastasis. It's nice to mention that this could be osteoblastic activity of famous cancer that like to spread osteoblastic lesion as what? If you think about the primary, it will be prostate. Excellent. So this could be prostate cancer metastasized. If this patient is female, it could be okay. Let me ask you one question. After 2 years, this patient came with this appearance. My question for you is, this patient have regression or progression? What do you think? And why? Everyone agree with the regression? Everyone agree? Or some people will not agree? Who will not agree with this? We mentioned something very important. Yes, Ruba. Excellent. We mentioned that you have to check first the renal uptake and soft tissue uptake. You remember this rule? So go back. Yeah, it was here, and there was many metastases. But right now, what we have? Yes, we have super scan. So my question for you, is it metastatic or metabolic? Metastatic. Sure, that's metastatic. Why? Axial skeleton mainly involved, proximal appendicular, which is typical for metastatic super scan. So right now, this patient have progressive course. Don't forget. Take care from such tricky cases. This patient have chronic, she is adult female, and she have a chronic history of pain in the leg, and they did for her this bone scan. What do you think? What is your differential? There is intense uptake in the left tibia. What is your differential diagnosis? Okay. Good differential. Anything else? Can be neoplastic, can be fracture, non-ossifying fibroma, adamantinoma. So what is your next step? What is your next step? Everyone say X-ray. Unfortunately, this patient did MRI. Do you agree? Do you think that this MRI add for us something? This is the pre-contrast T1, and this is the post-contrast T1. Do you think that this is This have anything? What do you think? Yes. I told you in the start, this patient is young adult. So it can be. Yes. So next step, everyone agree? It is X-ray. Yes. This patient, if he did X-ray, we can reach the diagnosis. So what is your final diagnosis in this case? It is ground glass veiling, long lesion in long bone, typical for fibrous dysplasia. Excellent. So this case is fibrous dysplasia. This means that if you see bone scan and you have uptake, don't think about just metastasis. Don't think about aggressive lesion. It can be benign lesion. Some benign lesion can have uptake. And there is something good in fibrous dysplasia in such case to know that you can say that this fibrous dysplasia monostotic or polystotic. What do you think? Was it monostotic or polystotic? What do you think? Yes. So if it is polystotic, as you know, it will be another differential and another syndromes. Okay. Another patient who is a bit old and he did this bone scan because he have pain. They did for him because he have chronic pain. So if someone saw this before, he will say that is this typical for, yes, I can see there is attack in the chat. Everyone say this is Paget disease. Exactly, this is Paget disease. This is typical for Paget. And when you describe, you have to say this is intense uptake, intense uptake. And again, you will say that I will correlate with the radiographs, X-ray usually, yes. And yeah, this is polystotic Paget, exactly, thank you. So this is a typical case of Paget, which is again, frequent exam case. Let me show you something. First, I can show you this study of patient. She have fatigue and weight loss, and she did this study. What is the name of the study? Anyone know? Yes. So it can be thyroid scan. Yes, it is thyroid scan. So in this case, what is the abnormality here? What do you think? Hot nodule. Yes, it is hot nodule. Yes, that's nice. Hot nodule. How you prove that this case is toxic? Do you have any proof for that? How you prove this? Yes, the background suppression. Excellent. The background suppression. So you see nodule with intense uptake, and you cannot see the thyroid, normal thyroid background. This means that this usually this is the toxic adenoma. And again, you will correlate with the ultrasound. So let me show you now another study, another same study, but don't be panic. If I show you the black white and the white's black, this is the same study. So in this study, if you just reverse your standard, so what do you think? What is the abnormality here? What is the abnormality here? Yes, excellent. This is photopenic area in thyroid gland in the left side. So it could be cold nodule. So is it the cold nodule suspicious nodule or not? What do you think? And what you will do next? Yes, It's a suspicious nodule, so you have to not stop. You have to continue that this could be suspicious nodule. In that case, I will think that I'll do ultrasound and this patient need biopsy, okay? So in that case, I think everyone will be happy if we mention that this case need biopsy. So this patient have pain. He cannot support the pain, and he did this study. He have pain in the foot. What do you think? If there is anything you could think that this patient have to be worried or not in this bone scan. Yes, this patient have something, have degenerative changes in the knee. Exactly, yes, have some degenerative changes in the ankle. That's good. And some spinal changes again. This patient need to be repeat some views, okay? So we'll have to take some special views in these areas. Let's take these views, try to find the abnormality. So in this case, do you think that this patient have abnormality or not? Yes, where? Right or left? Yes, metatarsal. There is hot uptake. This patient did SPECT CT to confirm the location. So what do you think? In that case, what is your differential? Again, yes, it could be common site for stress fracture. This is finally stress fracture. This is stress fracture. Yes, this is common site of stress fracture. This patient came that he have some abnormality in the ultrasound. Then they asked to do this scan. Do you think that there is abnormality in this scan? And what is the name of this scan? Do you know the name of this scan? MAC3, yes, dynamic renal scan. So in this dynamic renal scan, where is the abnormality? Is it left or right? The abnormality is left. Why is left? Because you can see the left kidney take the renal uptake, accumulation, and without any wash. And when you do some split function, you can measure the uptake in both sides. And again, you find that the residual in the left side, because we are in posterior view. So on the left side, you can find that is much high. This patient have obstruction. Usually, they mention that it is BUG obstruction, Pelviureteric junction obstruction, Pelviureteric obstruction. One patient came with history of aggressive type of lymphoma. And while you check, you find that this patient have such appearance. What do you think about this appearance? And what is the study? Anyone know the name of this study? This is BET. Yes, this is BET study. And if I show you something, another, maybe like this pattern, anyone know this distribution, what could be? Or maybe I can show you more obvious this image. Yes, this could be what is called brown fat. So take care about the brown fat. Sometimes can mimic some diseases like lymph node. In such case, especially in the bit. So in such case, you say that I will correlate with the cross imaging of the CT with the bit or maybe fused image, and I will check. If you find that the uptake in the fat, so that means that it is fat, and if you find that there is lymph node, so you can say lymph node. But this typical pattern of what is called brown fat, which is normal finding. So this is normal finding. This is in bit scan. So let's go for more cases. And when we mention the bit scan, let me show you one more case of FDJ bit CT for this patient who presented with pain in the thigh. Where is the abnormality and what it could be? Yes. It can be this patient have intense metabolic activity along the intramedullary region, and it have also soft tissue, aggressive reosteal reaction, or you have to check it. Yes, sure. But in such case, we think about something in the neoplastic lesion in the bone, and it come in the diaphysis. In such case, we think about either osteosarcoma, which is more common in the metaphysis, right? Especially the distal femur. But if you find it diaphyseal, so as you mentioned, we think about something like Ewing sarcoma. Don't re-panic if he show you like such case and he asks you about something. This is physiological uptake in the kidney and in the bladder. It is just physiological uptake, but you have this pathological uptake, and your interpretation is the same. You don't have to change anything. Okay? So let me show you another case. Well, this patient have pain and he have history of myeloid leukemia. He did this CT study, or let's say he did this X-ray first, and in the X-ray, they don't find any lytic or sclerotic lesion, if you agree with me. Everyone agree? Do you have any lytic sclerotic lesions? Yes or no? Yes, most is normal. And for such reason, they suggest to do CT. And actually, this patient did this low resolution CT. And they didn't find anything. So this patient did this study, which is the bone scan. So do you think that there is any abnormality in this case? Yes. Do you agree that there is some focal uptake here in the proximal tibia? Everyone agree? It could be something. In that case, they do SPECT-CT. When they do the SPECT-CT, they find that this is correlate with this uptake. What is your differential diagnosis in this case? Do you have any differential, bilateral, other symmetrical? Patient with history of myeloid leukemia. So again, we can think about stress fracture. Excellent. My next step will do MRI. And yes, we find that there is typical appearance of MRI for stress fracture. Excellent. So another case of patient who have some abnormality by ultrasound, and they did for him this scan. Anyone know the name of this scan? MAG3, yes, MAG3 dynamic scan, and there is again persistent accumulation of the tracer. So we think about which type of abnormality. Anyone knows what it could be? So what do you expect in the ultrasound of this patient? What it could be the underlying pathology? It is obstruction. This patient have obstruction, BOG obstruction, exactly. And that's the appearance. So you will say, I will correlate. You will say, I will correlate with ultrasound to confirm my finding with BOG obstruction. This patient have history of leukemia. And again, he have pain in both hips. So they did for here this scan. Does anyone know the name of the scan after we show many studies today? What it could be? Yes, bone scan. Again, bone scan, MDB bone scan. Okay, so in that case, what is the abnormality here? What do you think? What is the abnormality here? Is it in the right or in the left? It is actually not super scan for some reason, but okay. Yes, there is left rib lesion. Actually, this is right, but okay, because this patient is posterior, so this is right. So again, we have something in the hips, if you agree with me. But what do you think about this structure here? Does anyone have? Yes, perfect. This could be transplanted kidney. In such case, you need to have another views. So you want to check the uptake in the hip and in the femur to check from the areas which have transplanted kidney. So does anyone think about what could be, what the abnormality? Why is there is patchy uptake in the head of the femur in both sides? This keeping with what? This patient have, yes, in the transplanted kidney, this patient usually takes steroids and finally end with which type? If you go to check for the MRI in this patient, what do you think? Yes, you will find that this patient have avascular necrosis, EVN, like this. You will find that this patient have bilateral avascular necrosis, which is a common finding, can happen with patient who have transplanted kidney. Yes, a bit difficult case, but yeah. Let's go more. more difficult a bit. This patient, 6 weeks, years old, and you have this pattern in the bone scan. What do you think? Where is the abnormality? We need to go more focusing in the abnormality. Let's go more focusing. Yes. Where is the abnormality? Who will take the gift of the day? The gift of the night? This night, who will take the gift? Who will take the gift? Yes, Noha. Perfect. Noha. I am thinking about the posterior rib. Posterior rib fractures. It can happen, and it shows this uptake, this type of uptake in this age group. You have to worry about non-accidental injury. I will do for this patient urgently skeletal survey and CT brain. This patient is non-accidental injury. You have to mention this for the examiner. Excellent. Bravo. So I am going to show you another case, and I will be happy if you told me what it could be. This study. Anyone know the name of this study? Yes, PET-CT, FDJ PET-CT. Perfect. And what do you see in this patient? Do you see that there is pathological uptake here? You agree? Everyone agree? Yes. But take care. This is in the liver is physiological, in the kidneys is physiological, okay? So don't be. But this one is pathological. So you have in the PET-CT to differentiate between the pathological like this and the physiological like this, okay? So you go also to check for the CT images to confirm the location, the anatomical differentiation, and so on, okay? In that case, everyone agree there is stomach lesion and there is multiple lesions. So what could be your differential in such case? Could be carcinoma, stomach carcinoma. Do you think the stomach can have metastasis as well? Can have metastasis. Do you think that can happen? Yes. What could be the metastasis in the stomach? From where? Melanoma. Yes, this case was melanoma. Excellent. Bravo. So as you see, the same interpretation, you know, but just in another type. You have to arrange your informations, your study, and just the examiner will be very happy for your answers. As I told you, it can start with nuclear case, and it can start part of the study. So this case, what do you think? This patient came with this appearance in the X-ray. The lesion is lung lesion, mediastinal lesion, chest wall lesion, neck lesion. Where is the lesion here? What do you think? Mediastinal, everyone agree? In such case, everyone will be happy if you say that this is posterior mediastinal. Why? Why is posterior mediastinal? Everyone agree? Yes. So this is posterior mediastinal lesion. In such age group, you are worried about neuroblastoma. So what is your next step? You will do cross-sectional imaging. Yes, Noha, perfect. And you will do, what is this study? How do you confirm? By this study. This study is what? MIBG scan. Yes. In this scan, you not just confirm the primary, you confirm the primary, and if there is also, what? Metastasis. Perfect. So in such case, you are worried about metastasis. So there is no metastasis in this case. So you have to mention that this is neuroblastoma. Okay. This patient came with cough and dyspnea. What do you think? I want three words in this case. The examiner will be happy if you just mention 3 words in this case. Left or right? Left or right? The region left. Okay. And you have 2 words now to mention. Just 2 words is enough. So what do you think? Right, left. We say left, yes. What do you think? What this patient have? Collapse. Yes, collapse. Upper collapse, lower collapse. Left upper lobe collapse. Excellent. What you will do next for this case? CT chest. Perfect. What do you think? What is the cause here? There is endobronchial lesion. What is your differential? Lung cancer, most common. Carcinoid, it could be. Metastasis, could be also. What else? Infections, whatever. But what we will do next? This patient he will need staging. This patient did this study, which is FDG PET-CT. What do you think? There is uptake or not? Let's see the normal physiological uptake. This is physiological in the heart. This is physiological in the liver. This is physiological in the kidney and calyceal and the bladder. So all this physiological. So what do you think about the lesion? There is uptake or not? So this is typical for carcinoid. Sometimes it can show you after that one study, which is a octreotide scan, or this new scan, which is gallium dotatate, which prove that it is carcinoid. Okay. So in this case, this is the final answer. This patient have carcinoid. What do you think? Anyone know the name of this study? We mentioned it a lot of times today. What do you think? Bone scan. What do you think? What did this patient have? This kidney uptake, there is soft tissue uptake. Yes or no? Maybe super scan. But in such case, take care about something. What do you think about the bladder? The urinary bladder in this case displaced by something here. What it could be this? Yes, transplanted kidney. Maybe pelvic kidney. But do you agree that it could be transplanted kidney? Yes or no? Yes. What do you think about the appearance of the spine? Typical for something in your mind. The spine in this case. What do you think? Rouge-Jersey spine, yes. So in this case, I think everyone will be happy if you saw this appearance in the CT. So this is renal osteodystrophy. This case was renal osteodystrophy. Excellent. So this patient, young adult, who did this study, what do you think? There is intense uptake in the, yes, distal femur. So in that case, what do you think? What is your differential? Young adult, take care, Dr. Roba. Young adult, take care from the history. Usually check the clinical history. Young patient. Yeah, it can be infection. Can be. Perfect. Fadi. So what is your next step? You have to mention your next step. Yes, what is your next step? What do you think? It can be osteosarcoma. You think? Yes, this is osteosarcoma. And again, here in the bone scan, you have advantage of something. In the bone scan, especially in the osteosarcoma, you know that can have something called skip lesions. Do you know what is skip lesions? Someone knows? Anyone know what skip lesions? Yes, can have multifocal lesions. So this case, you prove that this case have one osteosarcoma. Yes. Excellent. I think we exhaust you with many cases. I wish that can be beneficial for you today. Let's end with this, inshallah, تكون easy case with patient who have pain in the lumbar spine, and he did this 2 X-ray views, and there is some scoliosis. Did anyone see something here or here before we finish? End case, yes, absent pedicle in the second left. Next step, we'll do this scan is again bone scan. And what do you think? Multiple lesions. So this patient keeping with metastasis. Thank you. I wish you enjoy this today, and I will keep you to continue with Dr. محمد. توفيق لكم جميعا وجود luck في الامتحان. موفقين إن شاء الله. أشوفكم على خير. إن شاء الله أشوفكم على خير وتوفيق. حالكم الحظ إن شاء الله، ونتمنى نسمع عنكم كل خير كده، وتبعتوا لنا بشريات إن شاء الله كل الأمور عندكم تمام. سيبكم مع دكتور محمد. Leave you with Dr. محمد. They will start now. See you. السلام عليكم.
Hello, everyone. Just a minute. We will start. I will ask September candidates to leave now and go to sleep because we will discuss some things related to our colleagues in the next settings. We'll discuss with you if you read me plan. Because many people are asking about this. So it's very important to have a look about our plan for practicing. Just let me join through another device to be more clear and the voice to be clear. Just a second. I hope you can hear me well now. I will share the screen with you.
And here is our courses that we are routinely run for 2 week exam. And I don't know. I think there is no. Yes. We believe that overseas candidates need long time preparation for this exam, and because we are not in the UK system, and there are a lot of differences between our systems in training radiology, and maybe there is a lot of defects regarding the preparation for 2B exam exactly. And our plan are based on the long time preparation, and this is not maybe not the routine in the courses market. The most of the courses are 2 days, 3 days, and it many times it's near to the exam, so there is no time for repair. If you have a problem, it's maybe very tough to find the time to repair these problems. So here our plans are designed to help you to overcome all the struggles and obstacles toward your success. And Alhamdulillah, our feedback is very, very, very nice, and the scores of our candidates, especially in the private Viva, is very high, mashallah, and very good one. Uh, 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 and this reflecting how you need to prepare very long time before the exam. Our plan starts maybe about 3 months or 4 months at least before the exam. You need to go through different courses, and many of our colleagues, when they are going to our website, they are facing a problem to understand what all these courses. So here I'm trying to summarize this one and try to make it very easy to understand it. We have, as I mentioned, courses. It will go through after each other. So we will start with case-based approach course. Then after we finish this one, we start the Triple M course, and if we finish, we have a private Viva course. So every course of these courses will focus on one of the major problems that we face in preparing for the exam. Uh, 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 I will start with case-based approach course. This is a 12 session of Viva practice. You are practicing Viva through uh, uh, the major differential or common differential diagnosis in the curriculum. We are dividing the curriculum 6 modules. Each module will have 2 sessions to discuss the common differential diagnosis. This come in private or in mini group action. You will be privately total, or you will be within small group, maximum 3 candidates. So we start to make these cases together. In the 12 sessions, we are covering the most common scenarios of the common differential diagnosis come in the exam. What we will get from this course, firstly, we'll solve the major problems of talking on the film and describing the lesion and having an approach. This is a big problem. It will need time to build this ability to and this skill. It will need it takes time to develop this skill. So in January exam, we will start in first week of October, and we will finish the case-based course by the second week of November. So if you are planning to join the January exam, this is a time for you. Also for March, you can also make this in much longer time, and then you can have a good preparation before the exam. Triple M course is 15 sessions in 5 weeks, 5 rapid and long reporting exam. Every week you have an exam like the exam you'll have in your exam day with feedback. We will mark this this exams and send you the personal feedback about your performance, the major defects you have, the major problems in your typing, in your description, in your interpretation, and we will discuss all these cases also in a general session together. Okay, this is the first 5 reporting sessions. Also, we have a 10 hot seat sessions, and this is similar to, and we will start to give the basic tips and tricks for the exam preparation. In this course, you will have a very nice discussion and very nice cases. All of these cases come in the exam before, so it's a very common exam cases, very common scenarios. You will have this by practicing and listening to our other candidates who are practicing together. So it's a very it's like a brainstorming activity. You will have a practice within it. You will listen to other colleagues. You will listen to the discussion with the examiners and the instructors in this course. This course will start for January exam in the 3rd week of November and will finish by 5 weeks from this date at around 25 December or something like this. Then the private Viva course, this is the last major course we are preparing for the exam or to be exam. In this private Viva course, you have 5 exams exactly like the exam situation. And we have 2 options here. You can choose 1 room, 5 exams, 1 room, or 5 exams, 2 rooms. That's mean in the 2 rooms, you have the full exam as you are in the exam with 4 examiners. And it's very, very, very good one. You will be prepared well for the exam if you got these courses, especially private Viva course 1, because it's very similar to the exam situation. So your exam date, this is the 6th time to have an exam. It's not the first time. You have 5 exams. You are totally private, private with the examiners, no one with you except the examiners. You have 2 rooms, you shift, and then you will take feedback after we finish asking you and presenting the cases with you. And it's very tough, like the exam. The examiner will be sometimes aggressive, sometimes like in the exam. You will have different personalities, different cases, different situations. So you'll be prepared for everything. Okay. And this this activity will be for January between the last week of December with the first week of January. Regarding the Eagle Eye course, this is a rapid reporting intensive course. This is with Dr. Mahmoud Al-Saidi. And the exact date, exactly, we didn't decide. The 2-day live session, we didn't just announce this one. But before the 2-day, we have a 1 week of active on the intensive preparation with Dr. Mahmoud Saidi on the private group of the course. He is providing you with many exams you are solving as a homework, and you are he will ask you to see and review the free content of the Eagle Eye. So, and then in the 2 days of the live course, you will have very nice tips, tricks for the rapid reporting exam, and then you will solve with him live about 10 exams of rapid reporting on RADME platform. And I want to share with you our website. You can see here our website, radme.net. we have a bundle for FRCR 2B in January. If you look for this one, this bundle consistent of the Triple M course, or private two-room course, and the FRCR 2B reporting on redmi.info. I will show you the website now as well. And here also the FRCR case-based approach course in the mini group. All this bundle having a discount of $750 discount at this point, so you can book it, and it's very nice one for you to prepare for the exam. Regarding redmi.info, I'll show it with you also. Okay, we have packets, our products here. We can see it. Okay, you can find this already. You have a demo. You can free demo to practice the exam and see the platform. It's simulating practice software, and it's new in the market. We are in the testing phase in the last 6 months, and we are now ready for the market. So you found this packet is having 50 packets in 3 months subscription. I have discount 30% on this one, and also long reporting daily case practice. We found that many of our colleagues are booking the websites, and they are not practicing long reporting on the websites. The cause is that to practice long reporting exam, you need pure 1 hour at least, with a very good situation around you. And if you did it one time, you will not do it the second or in the third time. So we made some attractive and very good one, is one case in 1 day. Every day you have a case in 10 minutes. You prepare yourself to type fast and to be limited to 10 minutes of to finish the case. If you practice on this, you can upgrade it in the second. After 1 week of practicing, you can do 2 cases in 1 day. After a while, you can do 3 cases in 1 day. So you are gradually prepared yourself and train yourself to practice. You will have a 60 case in this package if you book it. Around 10 exam cases, 10 exams of long reporting, 60 case, but it will be separated each case alone. Okay, so you can on the same practice similar software, like in the exam, the shortcuts, everything like practice. The only thing you will have support icon if you face any problem during your practice, or timer which allow you to see the timing. And because this exams time management play a very important role in passing the exam, so consider the time. So here you can book this discount is for the first 50 subscription only, and will be another packets. I think they by the 15 October there will be 90 packets for 6 months. It will be available, and also I think they will add another packets regarding long reporting as well. So just keep a look, and inshallah, maybe by the 1st of October, the marketing team will allow the candidates to practice maybe 5 exams of rapid reporting for free for 1 week, and some cases of long reporting for free, to allow you to check the website good and book with confidence the packets. I hope you. I don't want this to be very long, and I want it to be concise, because I know talking about courses and things may be tough, But if anyone is interested, he is interested in this or of any of these courses, he can contact me directly. We will discuss more together. Any issues, I will explain anything for you privately if you want. I just need you to know that passing a FRCR exam needs um, more efforts. It's a tough exam, I know, but it's easy if you took the advices. You you are focused and you are planning well, and don't forget. Uh, uh, don't play the game. I will try this time, and then I will see if I can pass the exam. Don't play this one. Don't play this game. Prepare well. Best time or best chance for you to pass the exam is the first one. Take this one. Take this advice, and this is the last one. I will end the session with it. Inshallah, we will make a near maybe after 1 week or something like this. We will discuss our rapid reporting session about tips, tricks on rapid reporting, because we we heard a lot of problem with many candidates preparing for rapid reporting. So we will advise you to attend this free activity. Inshallah, we will announce this on the website. Thank you very much all, and I hope inshallah you enjoy this lecture with Dr. Mahmoud Rizq, and we will arrange inshallah a lot of activities in the few days. Just keep in touch. Thank you very much.